Hello, everyone, and thank you for joining us. My name is Karen Eggleston, and I'm Director of the Asia Health Policy Program at the Asia Pacific Research Center at FSI at Stanford University. Delighted to welcome you to our final colloquium of this spring quarter and the APARC series on COVID-19 in Asia. Today, we have many experts joining us. I will only briefly introduce each of them. Some have been pre-recorded to share their expertise from Asia, and others are joining us live. So we have experts from Asia, including Dr. Prabhakaran, who is Professor of Chronic Disease Epidemiology of the Public Health Foundation of India and Executive Director of Center for Chronic Disease Control. We also have Dr. Pham, member of the Vietnamese Steering Committee for COVID-19 Prevention and Control, who's an expert in infectious disease surveillance, with professional experiences from Thailand, Norway, and the UK. We have Dr. Hạc of Nguyen University in the northern part of Vietnam, sharing some of the experience of helping healthcare workers on the front lines and near the border with China. And then live today joining us, we're very thankful to have Dr. Richard Cash, who is Senior Lecturer on Global Health at the T.H. Chan School of Public Health at Harvard University. Dr. Cash and his colleagues conducted the first clinical trials of oral rehydration therapy in Bangladesh and is famous for many other studies as well. And we are very grateful for his expertise with us today. We also have two Stanford affiliates joining us today, Dr. Radhika Jain, who is the Asia Health Policy Postdoctoral Fellow at APARC, and Dr. Arzan Terapur of National Bureau of Asian Research and other affiliations, and we're delighted to say will be joining us here at Stanford in September. So starting the webinar today, I will first share the recorded sessions where I had a Q&A with the colleagues from Asia, and then we'll go to our live webinar. I would encourage all of you to enter your questions as you think of them in the Q&A function of the Zoom meeting.
Thank you, Karen, and the Stanford team for inviting me to say something on the situation of COVID-19 in India. The first case in India came on the 31st of Jan when a Indian student from Wuhan in China arrived in Kerala. And that was followed by 3 cases. So Kerala in south of India was the first state to have COVID-19 cases. And Kerala managed quite well in terms of containing, contact tracing every contact possible and contained the disease. But by March 15th, we had 100 cases and our first mortality due to COVID-19. So the government of India took a decision to lock down the whole country on the 24th of May. And we are in different kinds of lockdown all over the country even now. So the lockdown in totality lasted for almost 50 days, but right now we have these red, orange and green zones which have different kinds of lockdown, but all over the country we still have a curfew between 7 p.m. and 7 a.m. Having said that, there are certain features of the COVID infection in India. Most of the COVID infections are concentrated in a few states and a few municipalities or few small towns and corporations. I mean, nearly 60%, I would say, do not have COVID cases. Particularly the rural areas of the country do not have any COVID cases. It's mostly urban agglomerates which are observing huge number of cases. But we have not been overwhelmed as was seen in Italy or in New York in terms of the health system so far. So the underlying belief is that the mortality, COVID is somewhat mild in India and the mortality is low, or because of low testing, there's under detection of cases. Having said that, we have really not seen the kind of surge in the health system that has been observed across as many of these countries. So clearly the truth must be lying somewhere in between, that something is happening in India that you really do not have higher mortality as compared to other countries. It is, the case fatality hovers around 3%, but these are really significant cases because the early testing protocols meant that patients had to have symptoms for 3-4 days. They were quite sick, and therefore we are talking of really sick people. But right now the testing has expanded, and the cases are going up. So the the denominator is going up, the numerator is also going up, but not to the extent that we had thought it would. Therefore, the mortality would be lower. Currently, we have close to 100,000 people, and I would like to come back to the point as to why there is considered to be low infectivity and low mortality. One of the reasons people believe is that Indians have been exposed to several rounds of infection. Many of them do live in unhygienic conditions. So because of that, their natural killer cell activity seems to be better. It has to be proven, and because it's better, I think it fights the coronavirus infection in a better way as compared to naive population who are not exposed to any kinds of infection, who live in a very sanitized environment. That's number one. Number two belief is exposure to malaria somehow, because the receptor in the cell is very similar. Maybe there is upregulation of the receptor or downregulation, whatever the case may be, and that might help. That might prevent Indians by getting infected. The third is BCG vaccination. There's universal BCG vaccination. Even immediately after birth, within 2 or 3 days, children get BCG vaccination, and that also is believed to increase the natural killer activity. Or there may be some other inherent differences. The virus could have mutated, or the temperatures that are high may have prevented the spread of the virus very rapidly. But all these are conjunctures and required to be proven by studies. So, having said that, I'm a cardiologist, and therefore, heading the chronic diseases division at the Public Health Foundation of India, and I would like to talk something about the NCDs, non-communicable diseases. So there are issues with non-communicable diseases. We all have had that, how comorbidities are increasing mortality and are the major cause of mortality in the United States, Italy, and China. But I think one need to look at age-adjusted mortality, and with age adjustment, I think it may be age itself which is the driving factor rather than the comorbidities. But in India, particularly because right now we have almost 79 million people living with diabetes, 200 million people living with hypertension, a million people dying because of tobacco use, 500,000 people dying of alcohol use, 1 million people dying of cancer, and nearly 30 million people living with cardiovascular diseases. The propensity to uh, have a higher mortality because of these comorbid conditions seems to be higher. We have not empirically looked at the kind of data to see whether indeed this is the case. But the bigger problem is there are likely to be mental health issues for having been in lockdown for such a long time, particularly amongst children who have to have online classes. And again, an empirical evaluation of how this impacts children's mental health requires to be done. In terms of cardiovascular diseases itself, there are 3 or 4 things that happen. Number one is empirical, not empirical evidence, anecdotal evidence suggests that there is close to 25% reduction in emergency admissions in the country. Whatever emergencies that come to the hospital have severe problems. They come in the extreme end of the disease, and the mortality of people coming to the hospitals may be higher. But given the fact that there are 25% lower emergencies, people tend to believe that actually there is a reduction in CVD mortality, but it may be because the pollution levels have come down considerably. It may be artifactual because the road traffic accidents also have come down because there is virtually no traffic on the roads. The second thing that happens is there is a reduction in compliance to drugs, particularly diabetic and antihypertensive drugs, because these are asymptomatic conditions, and when it is difficult for patients to go and get medicines, they are unlikely to take these drugs, and that would result in lower compliance. The third, it affects the poor and the elderly and women much more than others, essentially because when there is a fall in the income of people, one of the things to get hit are these drugs, lifestyle drugs, essentially because people perceive that it's really not required, particularly statins, for example. Nobody would think, bat an eyelid to stop statins if they have to save some money. So elderly would get affected. Women given that when you have acute pulmonary syndrome, we did a registry almost 12 years back when we found that nearly 60-70% of people were either using public transport or some form of private transport to come to the hospital. And given the fact it was so difficult now for people to come to the hospital, they would not come. And elderly particularly have a fatalistic attitude, saying that I have finished my evening, so why do I need to go to hospital even under normal circumstances, would even more be convincing so now. And therefore there may be unaccounted mortality, which we are not really getting into the numbers that we have. So these are some of the things, and the exact causes of cardiovascular death is also not clearly known. So we are embarking on a registry to look at what are the cardiovascular manifestations. Is it because of secondary myocardial infarction? Is it because of direct damage to the heart muscle because of the cytokine surge? Is it because of drug toxicities and drug interactions? Is it because of pulmonary embolism? So these are some of the things that really require inquiry. But in terms of moving forward, I think we're going to have a new normal while we are awaiting vaccines and new drugs. In India, there are 10 different trials that are going on, both with international collaboration and locally. Vaccine production also has been is being explored, and people are positive that we might get a vaccine within the next 9 months or so. But till then, we will have to follow these social distancing norms, and we'll have to wait and see in the winter what happens, and probably we'll have to reintroduce lockdowns for some more time, which is going to be really difficult, and it is going to be economically disastrous for people. I don't know how the governments are going to do it. Is a Hamletian situation, to be or not to be, or in terms of choosing between lives and livelihood. The one big problem that now we have now is stigma, and we need to educate people, because stigma prevents people from coming forward when they get infected or when they are at an early stage. And therefore I think massive education is needed in terms of stigma.
So the control measure is in Vietnam is totally different with other country because we afraid, because we know that the resources in Vietnam is not support us if we have a lot of patients. At the beginning, we know that we have only 3,000 ventilator. We have about 4,000 to 5,000 ICU room, ICU bed. It is very limited resources. And if we have something like 3,000 severe cases at one moment, at the same time, then we will have die. We will have someone die. That's the reason had been very clear to show the publics that we are in a situation that we have to fight the disease from the very beginning rather than waiting it to come in. So instead of waiting for number of patients increase every day, we decide very early about close the border with China. And we test everyone coming in the quarantine once they come in and before they discharge from the quarantine center. Once we have case, we not only the case is the one who coming back from high risk area and tested positive, or the one who have symptom and test positive. It means everyone have positive, considered as a case. And from case, we have round one contact. It means the one who have a close contact with the case. And from round one contacts, even they don't have symptom, they have to go to the hospital to quarantine there. And from the close contact, we also check any close contact with those. It means the round number two. Everyone contact with the contact number one also have been stay home, waiting for the result from the round one contact. And if anyone in the round one contact turn out positive, the round two contact have to go into hospital to quarantine also and test. It means they are treated as the round one contact. And so on, we ask the round two contact to contact with round three and round four, just to warning them that we are at risk. And we have to wait for the result from the round one, from the any one of them confirm or not. But when we do like this, it means round 1, round 2 contact have to stay home and have to test. We think that with that strategy, we can catch up with the move of the virus. And that is the reason why we test a lot. We have about 300,000 tests so far and catch only 300 something patient. It means one patient, it costs us around 1,000 of tests. It's a lot of tests per patient. Just to make sure that we not miss anyone, we not miss any contact that might develop disease in the future. So that is one of the strategy. And other thing is contact tracing. Contact tracing is not only based on the information given by the patient, but also from people around. I mean, we interview everyone around the patient, and we ask the whole system to work, and the whole system includes the 63 CDC center, more than 700 of district health center, and more than 11,000 of community health center have to work on the contact tracing. Other people that also work with contact tracing is the police, is the soldier, that also help us to provide information and also help us to fight the case. And the transparency of the information is one of the key factor that lead Vietnam to succeed, because we have to share information as fast as possible in order to find the contact, and people are not afraid of being found. What I say here is the transparency of information, and all the information from hospital had matched with the information from the government portal, and match with the information in the social media, and match with the information in the mass media, and so on. It means everyone know about the COVID-19 and people aware of that. The lesson learned from that is what? The first thing, rapid response. Yeah, we have to have very quick response before we have any warning from WHO guideline. We cannot wait for WHO guideline. We have many experience dealing with previous disease. Other thing that we say is clear leadership, a clear message that I already mentioned, and other things is the support from the government, support from Ministry of Health. That a very, very clear guideline have to send to all level to make sure that everyone know the guideline. Everyone have to know what to do, how to deal with people coming back from the border, how to deal with people coming back from abroad to the airport and so on. How to deal with patients have been found, how to deal with contact tracing, and every single thing.
I just had one question. If someone is in quarantine, has another health condition, how do they receive medical care while they're in quarantine?
They will be transferred to the hospital to treat, and the hospital is the hospital assigned for COVID-19. So they are treated, their medical situation, and so on. Yeah.
Well, thank you so much for your time. I know you're very busy and have a meeting, but it was very gracious of you to share this information. Is there any final thing you would like to share?
Yeah, actually, we had to deal with the new wave because we cannot wait. We still have to continue with the economy development. Yeah, people have to work, and so far people now working. We now only close to the outside. We open for the inside, and everyone work like normal, almost similar as before. But only in the crowded setting, we still ask people to wear masks and precaution. And we ask anyone who have symptoms to have tests and tests and tests. I think tests. Almost, even now, we still have a patient coming from outside. It's a lot, but we have to deal with that. And that's what we have to deal, because we still have to bring people back.
we have to develop the training program for how to deal with COVID-19. We continue. So that's why we have to prepare the document and the training program for teaching and the training, the short training course for the teacher and the final, the last year of student, because we have more than 1,020, 200 of student, the final, the course final year. So we prepare to come for the finish. So we have to prepare everything to skill and knowledge for that kind of research. If the COVID-19 occur again, we have to deal with all these resources to be help the community to how to prepare and deal with and prevention and everything for the in the future time if the COVID again. But in life we have prepared everything for the in future. So that's why we have to change a lot of activity, also teacher and the student, and training program in our, and also thirdly, we also have to prepare one research. We have carried out a research already. What impact of the COVID-19 to the mental health of the health staff in the rural area. Almost we focus on the primary health care level. For example, district health staff or community health staff or the village health worker, how they thinking and how they know about the COVID. The people in the community, it seems that it's not so much the people worry about the COVID-19 because they don't know what is it. They don't know what happened. But for the health staff, they more than people. I think that for the 50%, 57% of the health staff, they are worried about the COVID-19 because they have no idea about how to deal with and how to happen if they have one the patient occur or a positive case in their community. So they could feel that is why we have to teach for the young teacher and residency graduate and like to the postgraduate student.
I think now we'll turn to our live webinar. And after hearing from our colleague, Dr. Bach, about the northern part of Vietnam and dealing with the rural areas and supporting the health workers there. So now without further ado, we'll turn to South Asia, and I'll ask Dr. Cash to share with us his views about the policy challenges of dealing with COVID-19.
Thank you very much. What I'd like to do in the short time available is to look at South Asia in totality rather than each and every country, because we're going to see some clear patterns. For example, in Bangladesh, which is 165 million people, the first death was reported in March 18th, the first case probably in February, and they began a lockdown around the 22nd of March. It was predicted, or it was modeled by a group from Johns Hopkins, that there would be 90 million infections, 3 million would need hospitalization, 700,000 would be hospitalized, and 500,000 would die as of the 26th of May, which I believe was yesterday. To date, there have been 29,000 cases and 400 deaths reported, with the cases now beginning to appear in the Rohingya camps. So well below what was modeled. Now, obviously, things changed a great deal. This has had a dramatic impact. The lockdown and the global problem has had a dramatic impact on other parameters, shortages of food. 90% of people are in the informal sector. They don't have money. 85% of the exports of Bangladesh are in the garment industry, which is fundamentally closed down. And there have been many returning migrants from the Middle East. And the tests are some of the lowest in the world, about 400 per million. Pakistan, which has 220 million people, has been locked down since May 24th. Around the same time, the Prime Minister was reluctant to do it, but it was then ultimately enforced by the military. But that lockdown was ended on May 9th. Mosques continued to be open for prayer. Again, the first reported death was in February and the first death in March 20th. As of March 21st, about 5 days ago, there were 48,000 cases and 1,100 deaths. Again, well below what some had predicted. And India, of course, we've just heard about, where the population is 1.2 billion. The first cases, as was noted, appeared at the end of January in Kerala, which took a very aggressive position, much like Vietnam did, with contact tracing, a very strong social support network, airport screening, and they now have, coming up, 400,000 migrants are about to return to Kerala. But Kerala is not the rest of India. Kerala has had a total number of about 800 cases and 4 deaths to this period and to this moment in time. India, with a 4-hour notice, shut down on March 24th and continues to remain shut down. As I noted, Bangladesh ended theirs around the 16th of May, Pakistan the 9th of May, India is scheduled to end on the 31st of May. So the question really arises, what led to these enormous differences? I should note that Sri Lanka is very similar to Kerala, with 1,200 cases and 10 deaths. And Nepal, also very, very few cases, and theirs only 680 and 4 deaths. And their cases are occurring on the Terai border with India. So what accounts for this? A total number of cases of 220,000 with 5,200 deaths for a population of 1.6 billion people. We've seen different applications of lockdowns, some short, some long, some very, very hard, some very soft. So has that really had an impact on this? If one looks at all of Asia, the total population of Asia is about 10 times or 11 times that of the United States, okay? And yet the United States has 10 times more deaths. 11 times less people, 10 times more deaths. So what would account for all of this? Dr. Prabhakaran has given you a number of possible scenarios, including co-infections, BCG, malaria, early infections, and so on. Frankly, for me, it's hard to believe that this has any impact. After all, the elderly who are dying in the United States are probably the population in the US that has had the most exposure to these various things. And yet this has gone throughout Asia. Previous infections have been suggested, BCG, underreporting has been suggested, but to believe that through all of Asia and through all of South Asia is, again, hard to fathom. One thing that is very different are 2 things. One, in some countries, they took a very aggressive position in early case detection, airport screening, and so on. In Kerala and Sri Lanka and South Asia followed that model. Vietnam, as you heard, followed that model in Asia, as did South Korea and Japan and Taiwan. There's a huge, so that's one strategy. The other is that there's a very different demographic profile in South Asia, with many, many people in the younger population and very few elderly. Generally less than 3% are over 70. In the United States and in Europe, 99%, in my state of Massachusetts, 99% of the mortality is people over 50 and 96% in people over 60. So you have a very different profile in India and Bangladesh and in Pakistan. Also, we now know that that what is very, very deleterious to your health and more likely for you to get a severe infection is if you have prolonged contact in a closed environment. Now, much of South Asia, particularly this time of year when the temperatures are near 100, are outside a lot. The elderly do live at home, but they are not confined in institutions, as is the case in the United States. 60% or more of all the deaths in Massachusetts have occurred in people living in confined institutions. There are zero, or the reproductive rate, that is the number of secondary infections, has been used in most models is at 2.4. And yet in an open environment, as is seen in much of South Asia, this may be much lower, maybe around 1.2, because people cannot stay inside for long periods of time, especially given the high temperatures. So my great concern is that the medicine has been far more deleterious to the health of the population than has been the case with COVID-19. Dr. Prabhakaran went through a number of these. That is, there is a decrease in immunization rates. There's decrease in treating of chronic diseases. And education has suffered tremendously. Very few children have computers that they can learn from at home. And as I noted, 90% of the population is on a daily wage, or is not salaried, does not have a regular income coming in, and this has caused enormous disruption in the population, shortages of food, and so on. So as I note, my concern is that the medicine is worse than the attempts to reduce infection and deaths. And we have a saying in medicine, primum non nocere, first do no harm. And I'm afraid that much harm has been caused, even though we now know that both the prevalence, the incidence of disease, and the deaths are down throughout not just South Asia, but all of Asia compared to Europe and the US. Maybe the low and middle income countries represent the true impact of SARS-CoV-2 and not what is happening in the US and Europe. Thank you.
Thank you very much, Dr. Cash. And now we'll turn it over to Dr. Jane.
Thanks. Can you hear me okay?
Yes.
Okay, so I'm going to try to share my screen to show a few slides. So I'm going to focus largely on India, but I'll show you some data on all of South Asia, and sort of I kind of reached the same conclusions as Dr. Cash, but from a slightly different perspective. So I won't go over this, but I think the broad point has already been made that actually, currently cases in India are about 140,000 cases, which is much, much lower than, per population than in the US, and about 4,000 deaths. But the number of cases, is a function of testing as well. And so I just wanted to show some stats on some numbers from South Asia. So this is just data on tests per 1,000 people. What I think I wanted to, yes?
Did you share your slides?
Yeah, can you not see them? Let me try this, sorry. Can you see them now?
Yes, thank you.
Okay. Sorry, this is for some reason not quite. And so I think what I want to show here is, there's a bunch of countries in South Asia. The testing, the numbers of tests in South Asia are all quite low. I think two things worth pointing out is one, this pink line is South Korea, and what you see is that it started testing quite aggressively and early. But over time, it never reached the numbers of tests that places like the US and Italy have. It actually is kept, overall testing rates are fairly low, but the big difference is that it started early. India is very, very low. But if you zoom in, if you can see this, since March, testing in India has scaled up enormously by many, many factors. So now comparing, looking at testing compared to cases. So what this graph shows you is the number of cases, the number of tests for each positive case. So essentially the ratio between tests and cases. And that's a sort of more useful metric. What you see is in South Korea, you should probably don't look sort of over time, it's now at about 500 tests per case. Like essentially that as you scale up testing, you're reaching more and more of your population. How many people are you having to test to find one positive case? And South Korea is now at a point where it's finding very few infections per test. India, on the other hand, has stayed, going back to this graph, I showed you that the tests in the population have increased dramatically. The orange line here is the cases, the number of tests per case, and that ratio has stayed basically flat. And this, Ministry of Health officials have sort of talked about this as being a positive thing, but if you have increased your tests dramatically, but your positive cases as a share of tests is remaining fairly flat many weeks into the epidemic and many weeks into the lockdown, that's actually case for concern. There's caveats to all of this data, but essentially it sort of suggests that the infection is far more widespread than we think, and that testing is one of the constraints on identification. And it certainly doesn't suggest that sort of infection is under control. But one thing I wanted to show is that there's substantial heterogeneity within India. So this is some publicly available data on testing and positive cases that I put together. There are many ways you can look at this, but I think one thing to point out is this blue line here is Kerala. And what you see is Kerala started testing quite early. And again, as a share of its population, it never reached a very high share. There are other states that have a higher share. But if you look to the right graph, this is the same sort of tests per case, per positive case metric. Kerala, has its number of tests that it's needing to do to find a positive case has been increasing over time, which sort of suggests that it kind of has things kind of under control. And if as Dr. Cash mentioned, Kerala's strategy was a bit like South Korea's: test early and aggressively, but also importantly, use the testing data to identify, do contact tracing, and to contain cases. I think as an opposite sort of example, this orange line is Rajasthan and the red line is Maharashtra, both of which have ramped up testing dramatically. And if you look at their positive cases, it's stayed basically flat, or in Maharashtra actually gone down. So you're finding, despite the massive increase in testing, you're finding a lot of positive cases. Bihar is all the way down here. Bihar has very low, very, very low testing rates, and in fact is finding more and more cases amongst its tested. Which is sort of cause for concern. And it may be because, this may reflect migrants coming back, this may reflect increasing infection rates. It's a little hard to perfectly understand this data because we don't know exactly how testing protocols have changed over time. But the broad, I think, point I'm trying to make is one, that it's not clear that India is sort of magically kind of controlled its cases during this lockdown period, and that like cases alone don't need to be, aren't as helpful as looking at cases with tests. And so this is just very quickly confirmed cases in India. This is India is sort of on an exponential growth trajectory. And I think one of the things we, with exponential growth that is still very hard to internalize is that we're doubling every few days in the number of cases. So I haven't seen a lot of evidence that this lockdown has, we don't have the counterfactual of what would have happened without the lockdown, but it doesn't seem like the lockdown has dramatically sort of helped, that India has sort of controlled its infections during the lockdown. And the last graph, I think this Dr. Cash sort of referred to this. This on the x-axis, we have the median age of countries. And on the y-axis, we have the case fatality rate. And I think so far I've showed you tests and positives, and my sense is that the positive cases are going to keep rising in India. What is useful here is India's case fatality rate is quite low, and one major possible explanation for this is its population. So all of these countries up here on the right are wealthier countries with much older populations, and most of South Asia is down here. And so, I think my sort of main points coming out of all of this is, this lockdown was draconian more than most other countries I know, and extremely blunt, being nationwide. We don't quite know what would have happened in the absence of the lockdown, but it may have slowed things down, and it may have contained it geographically to some extent. But it seems that cases are still growing exponentially, and I don't think India can sort of assume that it's got things under control. And I'm extremely concerned about the non-COVID costs of this lockdown. And one of the things I've just launched a survey to look at sort of the effects of the lockdown on critical chronic care, so specifically diabetes and chemotherapy. And already the reports we're getting from patients is it's awful. So stay tuned for results. And then I think the second thing, I think there's a lot of discussion about testing, scale up testing. I think one, testing is not a panacea. It's what you do with the testing. And I think Kerala sort of is an example, just like South Korea, where you don't actually have to do a massive amount of testing if you can use that testing with other strategies like containment, like community surveillance, to sort of control things. But the other thing is that, I understand that there are constraints on testing in India, but conditional on the levels of testing you're doing, it's really helpful and important to make your data transparent so that the testing data can tell us as much as possible. And, the government is collecting data that it's not sharing on the age and sex breakdown of tests, of the district locations of tested people, and also whether they were asymptomatic or symptomatic, which would allow you, or how they were identified, which would allow you to infer a lot more about the sort of spread of the virus in the across the country. I think that's it. Thank you.
Thank you very much, Dr. Jane. Anyone who's joining us for the webinar, if you could type in your questions in the Q&A feature of Zoom, we'll get to those after our final speaker. Dr. Terapur, over to you.
Thanks very much, Karen. Can you hear me?
Yes.
Great. So what we've heard so far is a pretty comprehensive accounting of how the countries of South Asia and Southeast Asia are dealing with the pandemic domestically, dealing with the public health emergency. What I'm going to turn to is the second order effects, looking external to these countries and how the pandemic might affect especially their foreign and security policies. And I'm focusing now on India. I would argue that we won't know for certain the effects of the pandemic, except in hindsight. But I would still offer 3 areas for us to watch where I think we've already seen some indications of a significant effect. And years down the track, we may see the pandemic as being a turning point in these 3 areas. One is the opportunity for Indian regional leadership. The second is Indian military readiness and modernization. And the third is hardening views on China, India-China relations. So let me take these 3 in turn. First, not unlike the 2004 tsunami, the pandemic may wind up being an opportunity for India to play a larger role in the region. We've already seen India doing this in a direct way with one of the biggest, and planned to be the biggest ever repatriation operations run jointly by the military, but also by commercial air carriers. They just a few days ago completed phase 2 of that repatriation operation, with so far nearly 30,000 Indians returned to India, and the plan is for this to continue. In terms of regional leadership, especially in countries of the Southwest Indian Ocean, India has already provided food aid and medical aid. And of course, as the pandemic continues, the opportunity for the manufacturing of medicines, which will be exported globally, will potentially stand India out as a regional leader. Indirectly, however, the effects may wind up being even more significant in terms of international politics and security, because what we've seen is India reinforcing some of the nascent international political structures of recent years, especially, for example, and I don't want to get tied up too much on this one example, but especially the Quad, with the Quad plus discussions that have been happening routinely. This is the Quad of India, the US, Japan, and Australia. Added onto them, I think, Vietnam, South Korea, New Zealand, and in recent meetings, even Israel and Brazil, and the list might continue to grow. But the point is that the pandemic has offered an opportunity to use these minilateral, informal arrangements to actually address a pressing, urgent problem. So again, not unlike the 2004 tsunami, we see a bottom-up approach where they are seeking practical solutions to the crisis, which winds up really giving these minilateral institutions, or groupings, greater teeth and proven utility. So in the long term, on the issue of regional leadership, we may see India posturing itself to, along with a small group of highly capable countries, take regional leadership on long-term issues, perhaps in the future like climate change, perhaps in the future, if India postures itself in this way, to play a big role in global vaccine or therapeutic supply chains. That's the sort of stuff that will, over the long term, again, I say, mean that the pandemic will be a big effect on India's regional leadership. The second issue is military readiness and modernization. On readiness, we haven't seen much of an effect. The ships, for example, that we used to bring back Indian citizens, their crews were put in preemptive quarantine before they went, and we haven't. That's a dog that has not barked. Unlike we've seen in the US, readiness has not suffered apparently. The bigger story here, however, is on modernization. That is the pressing, urgent, overdue need for India to acquire especially high technology equipment. What we've seen in the last couple of weeks only is the military reflecting the government's wide-ranging emphasis on self-reliance, putting a greater emphasis on domestic production rather than imports of foreign equipment, and even, in order to do this, revising down the military services operational requirements for equipment. So the new Chief of Defence Staff has, for example, said that they will most likely shelve a major acquisition of fighter jets. They are going to build and over time expand a negative list of things that they will not import and that they will rely only on domestic production for. And so what you see is, probably for the first time in a long time, a reform of India's military modernization that will have far-reaching effects on what India acquires, what the Indian military acquires, and therefore the capabilities of the Indian military. And I'll come back to this at the end. The third area to watch for is India's relations with China. Now, India and China, at least at the official level, have had a fairly ambiguous relationship, especially in recent years. But what we're seeing, even from the early days of the pandemic, is a gradually hardening public opinion against China. Some public polling used to show a pretty high level of undecided or no opinion, public opinion with regard to China, and that has been shrinking. Indians are making up their minds on what they think of China. And that was even in the early days of the pandemic. What we've seen in the last couple of weeks is a big story on the line of actual control, on the boundary between India and China, where the PLA, where the Chinese military has launched multiple simultaneous incursions into across the line of actual control, and in some cases into undisputed Indian territory. This is, I would suggest, at least the biggest border crisis between India and China in at least 3 years, and depending on how it evolves, possibly the biggest since 1987. It's an open question whether these Chinese provocations have anything to do with the pandemic. Some have suggested that it is a Chinese attempt to demonstrate resolve or strength in the face of the pandemic. Whether that's the case or not, the border crisis, in addition to the pre-existing hardening attitudes towards China because of the pandemic itself, seems to suggest a step change in Indian attitudes, both elite and public, on whether China is in fact friend or foe. Over the long term, I would suggest that even if India's approach to China becomes less ambiguous and perhaps more hostile, we in the United States and across the region should not necessarily assume, therefore, that India will cooperate more with the United States. The distinction is that just because India may adopt a more hostile position towards China does not mean that an alliance with India, with the United States, is on the cards. The final point is, taking these 3 points together, it seems that there may even be some contradictions or trade-offs between them. So what I mean by this is, for example, that the declining defense budgets and the push for greater indigenous modernization may actually make it harder to compete with or deter China. So on the one hand, we see hardening views on China. On the other hand, we see a focus on a reduced focus on foreign imports of capability and modernization, yet those two things may wind up being contradictory, and one may be required to trade off against the other. I'll leave it there in the interest of time, but essentially the point I would leave you with is that this is the type of exogenous shock that may turn out to be something that everyone refers back to as a turning point on several fronts, but we probably won't know that for a little while. But there are certainly some early indications that it has far-reaching effects on foreign and security policy.
Thank you very much, Dr. Tarapore. So again, for participants, if you'd like to ask a question of our panelists, please type in your question in the Q&A. I'll start with a few that have come in previously that may or may not be provocative. China's come up more than once by our speakers. So some might want to know, was the lockdown in India and somehow trying to be even more outdo China? Do you think that played any kind of role? Another kind of question is about the capabilities in the health sector and producing pharmaceuticals in the region. We've seen generic versions of remdesivir starting production in Bangladesh and so on. Do you think that'll play a role in getting low-cost treatments available to the rest of the world? And I would invite each of you actually to respond to each other's comments if you want to respond to those questions or raise something in addition to what you previously said. So first, Dr. Cash, any thoughts?
Sure, thank you. First, let me respond to some of Radhika's comments, which I thought were very important. The testing is not an end in itself. The purpose of testing is to see what is happening to the epidemic. That's all. Now, if most of the epidemic is going to be in children and people under 40, where there's a very low death rate, who cares really? The whole purpose of all of the lockdown and so on was to prevent a surge in cases, and the health system in India, Bangladesh, and Pakistan is already at surge level. They're at capacity, so it doesn't do anything. And to prevent deaths. Now, if all of the cases are in a group of people who are not at risk of mortality and morbidity, then really, what is the purpose of it? Everybody has focused on this, but within the India, Bangladesh, Pakistan context, it may have less meaning. The purpose of this discussion is that the key element here is to develop a strategy which makes sense in your country with your resources and your capabilities, and to impose a lockdown in all of South Asia, which I believe was an inappropriate response to what now appears to be a situation of limited mortality and morbidity. Maybe they were trying to copy China. I have no idea. Maybe they were trying to copy Europe or the United States, but those are different places with different strategies. And one last point I want to make is a key element here is trust. It worked in Kerala. It worked in Vietnam. It worked in South Korea because there was high trust in government. Does that level of trust exist in the other countries of South Asia, the major reasons? And I would question that. So let me turn to my colleagues.
Thank you. Dr. Jane?
Sure. And actually, so Dr. Cash, I think we're agreeing. I think my point from showing the testing in cases is to show that I don't think the infection rate is under control in any meaningful way in India. I think I agree completely that the lockdown was, like I said, draconian and blunt, national, and I frankly, I think it was copying, well, sort of the policies in Western countries. I'm somewhat sympathetic to the government. Nobody quite knew. I will push back on the mortality and all that. We didn't know this at the time, right? That like early on, I don't usually give the Indian government some slack, but in this case, like we didn't know what the mortality rate in India was going to be like. That said, I don't think there was any excuse for the kind of a 4-hour notice nationwide lockdown that and I think what I'm trying to show with the numbers is that what we can see from the cases and tests combined, I don't think you can look at cases alone, but combining cases and tests, there are overall in India, the share coming back positive is very high. When you drill down down to the state level, and some people are going even further to the district level, precisely something like my point with showing Kerala, which is a bit like South Korea, is they didn't actually test that many. It's not a matter of pure numbers, but testing as part of a broader strategy to contain people and catch things early, I think makes sense. And Kerala, and Kerala is actually, Kerala comes up often as one of the states in India that does things in the health realm, right? But there are other states that have also sort of managed to do this. I think I'm concerned about states like, well, everybody's concerned about Gujarat and Maharashtra, and I don't think the testing data and cases data suggest that we aren't seeing any sort of turnaround in those states. I'm somewhat concerned about Bihar because we just don't really know what's going on in Bihar. The testing numbers are so low, but I completely agree. I think part of what I was saying, maybe not perfectly eloquently towards the end, is I don't think testing is a panacea, but and there's a lot of emphasis on like scaling up testing, which in a country like India, if you work there with the health system, there are lots of constraints. It's unrealistic to expect that it's going to reach testing levels of the state, like the US. And yes, I think trust in the health system is an important aspect. And I don't know what this lockdown has done. It seems strange. I would expect that people would be extremely upset about it, but it also seems like from some of the media reports I've read that sort of trust in the government, approval of the government is quite high, which was actually also true after demonetization. So anyway, I'm going off track there, but I agree broadly with you that I think testing is not the panacea. I think testing is, if you can be really transparent about your testing data, you can use it to understand what's going on. And thirdly, that testing combined with other stuff can help control it, but testing alone doesn't do anything. And let's all hope that the age profile continues to protect the South Asian population.
Thank you. We have some questions about testing. We'll come back to, but Dr. Terapur, anything you wanted to add?
Just a minor point on the idea of whether India is trying to mimic China. I mean, I'm not going to comment on the public health issues, but more broadly, I think what we've seen, rather than India trying to mimic China or to outdo China, what we've seen and what we might continue to see is India posing itself as a contrast to China. So for example, especially when we are talking about India as being an alternative to China in the global supply chain for manufacturers, India has changed some of its FDI rules. India is trying to pose itself as a contrast to China's failed mask diplomacy by providing things that work, medicines that actually work. So in many ways, while China poses an example, the point is not to outdo what China is doing, but to do something different and to pose an alternative to it.
Thank you. Some questions about testing, maybe for Dr. Kash and Dr. Jane. Have any models been able to predict downward part of the curve, i.e. when cases will peak and how fast they will reach zero, which has happened now in some countries? And a related question, as testing kits are limited and expensive, is it possible to test sewage for presence of virus like in polio and then lock down and test particular localities within a certain square mile or so on. Any thoughts on those questions?
In terms of the sewage issue, I don't think that first of all, it's going to help very much, except in a few cities that actually have a sewage system. Many of the, just to remind everybody that India leads the world in open defecation. So the sewage system isn't going to help much in that respect. I think it's probably too early to predict what is going to happen in a country so big, so vast, and so and with so many different states with different strategies, as Radhika has pointed out. I will say one last thing, though, responding to Arzan's comment. Really, there is no treatment for this condition other than oxygen and supportive care. The remdesivir is way overhyped. It has to be given intravenously, and it is only cut down on days in the hospital, not on deaths. So right now, by all rights, the United States should do very well because we've got the most advanced tertiary care system, and yet we lead the world in mortality. So the care issue, I think, should be put on the back burner, whether you have ventilators or you don't have ventilators and so on. I don't think makes a heck of a lot of difference in the long run. It's who gets infected, under what conditions do they get infected, and that is really, that to me, epidemiologically, is the most important issue.
Dr. Jane, thoughts?
Yeah, on the modeling questions, so I am not a modeler or epidemiologist myself, but I am working with this Stanford team of researchers that we are trying to do sort of subnational modeling of the epidemic of COVID in India. And going back to my point, I honestly, I wouldn't trust most of the models out there yet because I take that as agreement, Dr. Cash. No,
as I noted, there were the modelers said 500,000 deaths,
yeah,
in Bangladesh, and they're 800 or something. That's a hell of a lot off base.
Right. Well, there's the other side. There's the model that the Indian government put out, which predicted that new cases would go to 0 by May 16th, and we're seeing thousands of new cases each day. But I think to take this seriously, I think what's sort of extremely frustrating is that set aside how much you should be testing and all that. I know for a fact that the Indian government, that what is being collected on tests and cases includes basic data like their broad area of residence, their age, their sex, whether they were symptomatic or not. And from working with these modelers, it seems very clear that knowing those things about the people that you are testing and finding positive can tell you a lot more about the disease. And instead, if anything, testing data is being made less available, and a lot of these things that are being collected are not being shared. And so I think what I am starting to understand from working with these other people is that it's actually, this modeling is not trivial, and making data more transparent would really help.
Thank you. So in conclusion, we know there are many students and researchers here at Stanford and elsewhere interested in the region and wondering if there's anything we might do to help. That's one final question that I received earlier. I would like to turn that question and turn it back over to each of you to conclude with 1 or 2 minutes of final thoughts about anything that you think is important to share with us. Dr. Cash?
I would just go back to a point that I emphasized earlier. Whatever is done in any country, Bangladesh, Pakistan, India, Sri Lanka, Nepal, whatever, must relate to its needs, its demography, its resources, its own situation. That it would not be wise to copy the model from the US or Europe, unless it fits your situation. Kerala, it worked because their situation, they had a strong social network, a strong public health system that could take on these issues. But many of the states in India do not, and to impose a single national strategy in any of these countries was, I think, ill-advised and will continue to cause problems until some of these are changed. And also, we have different strategies. I noted Pakistan ended theirs 3 weeks before India did, and Bangladesh 2 weeks before. What is going to happen? What is the comparative there? This is one region which has a similar set of cultures and practices. So I would encourage your students to continue to focus in on the issues in South Asia. It's very, very important. There's 1.6 billion people living there. Let's not forget that.
Thank you. Dr. Jane?
Well, I mean, I think I've said most of what I have to say. I actually agree very much with everything that Dr. Cash has said. I think I would add to that sort of a theme that we touched on earlier, which is going back to this point of transparency. I think what has been, in addition to making things sort of customizing to the local context, is if you can, you know, if data could be sort of shared openly and transparently, the researchers and community activists and organizers and all of, you know, you can sort of crowdsource the response to COVID, and instead what we've seen in India is quite a sort of central command and control. And hopefully I don't get in trouble for saying this, but yeah, I think I'm not sure students can do very much about it, but that's my closing thought.
Very good.
Thank you. Dr. Terapor?
Similarly, I don't have much to add except to say that as Dr. Cash has said, that this is an inherently important region, but playing off that, riffing off that, the issue is that what we're seeing now is no longer, purely in terms of international politics, we're no longer seeing the United States leading the global response to this. The region is not just inherently important, but it's also important, I would suggest, as one of the vectors from which we may see creative and useful ways to not only combat the public health emergency, but also manage the second order political effects.
Well, thank you much. Thank you so much to each of our panelists, including Dr. Prabhakaran and Dr. Pham and Dr. Vak for sharing their insights with us. And thank you, Dr. Cash, Dr. Jane, and Dr. Terapor today. We look forward to your joining us for future events. Thank you all very much.